Top Med Talk.
Well, hello and welcome to Top Med Talk. We are broadcasting from Singapore for the World Congress of Anesthesiologists, hosted by the WFSA, the World Federation of Society of Anesthesiologists. Now, this event marks a significant milestone for the World Congress. That is the first in-person meeting in 8 years. That is incredible and crazy to say, actually. But I have to tell you, it is wonderful to be here. I believe right now we have over 5,000 delegates. That's the last number that I had heard that are here in the room with us. Over 500, almost to 1,000, I think now, of virtual attendees from over 142 countries. Wow. I know that is wonderful for the WFSA and the Congress. So congratulations to them. Now, in true Top Med Talk fashion, we are here in the exhibit hall having our engaging conversations with colleagues from around the world. And it is such a pleasure to reconnect with familiar faces, those who have been on Top Med Talk before. And really, honestly, we're making so many new connections with fellow anesthesia professionals that we've never met before. Telling them about Top Med Talk, asking them about and chatting with them about the work that they're doing in their little corner of the world, which is incredible. So we wanted to go ahead and dive right in. We have lots of conversations coming from the World Congress this year. So we wanted to dive into this next conversation as we talk about familiar faces, familiar voices, and those who have been friends of the Top Med Talk family. We have 3 guests that have been with us before, and we're so excited to be here in person having this conversation. And we're going to be talking about videolaryngoscopy and continuing that conversation from I believe we're at Euro Anesthesia 2023 in Glasgow. So we thought we'd sit down and see what's happening in the world of videolaryngoscopy. Now, our guests today, we have Ellen O'Sullivan, Patrick Schoedeker, and Ross Hoffmeyer. Guys, thank you so much for sitting down and joining us again. Ellen, I want to start with you and give you an opportunity. Tell us a little bit more about yourself if our Top Med Talk listeners haven't listened to that prior podcast.
Hi, I'm Ellen O'Sullivan, as you said, and I'm a consultant anaesthesiologist in Dublin in Ireland. I have an unhealthy interest in airway management in that my clinical work is mainly head and neck and maxillofacial type of surgical cases. I have been involved in the Difficult Airway Society. I'm past president of that, and just a plug, I am executive director of the World Alliance for Airway Management, and our meeting, the World Airway Management meeting, is going to be in Florence in November next year. So just heads up if you want another nice venue to go to, Florence in November 20.
Oh, that's perfect time actually to go to
25.
So, well, if people want more information, where would they find that?
They could go online, www.wamm 2025.
Oh, that's great. Yeah, we'll definitely check that out. I know there are a lot of folks who are extremely interested in airway management. That'd be a great resource for them. So, Ross, how about you? Why don't you tell us a little bit more about yourself?
Oh, thanks, Desiree. My name is Ross, and I am from Cape Town in South Africa.
Yeah.
I'm in the anesthesia department at WCA Hospital. We're connected to the University of Cape Town, and I am an airway and thoracic anaesthetist is the description I like. I run our airway and thoracic fellowship program there, which is still currently the only one of its kind in Africa.
Yeah.
So that's really exciting work. And I identify with Ellen saying that I'm a bit of an airway nerd and have been for a very long time.
I'd like to say enthusiast. Okay. Ross, I believe not the last time I caught up with you, but whenever we talked to you on Top Med Talk, it was during COVID. We were interviewing you virtually, and you're telling us a little bit about the work that you're doing down there.
Yeah, that's right. I got roped into the COVID Exco for our national society and we're involved with writing guidelines and dealing with our COVID response, and also on the shop floor, sleeping in the hospital 3 nights, every 3rd night rather.
I think you were just coming off call whenever we were talking to you.
It was a challenging time, but I think it was actually an interesting time for airway management. And it's been fascinating to see the development in the field, particularly we hear talking about videolaryngoscopy.
Yeah.
We actually just after COVID did a national survey looking at VL, expecting that as a developing country we'd have very few VLs around. And we've actually shown that 80% of operating theatres in South Africa have access to a videolaryngoscope.
Wow.
So it's become a very acute issue for us. A lot of devices, a lot of money was pumped in during COVID, and now I think we have a training deficit that we need to start catching up.
Yeah, I think we'll talk a little bit more about that as we get further into the podcast. Patrick, why don't you tell us a little bit about you? And I remember we also talked during COVID.
Yeah, thanks very much. Yeah, Patrick Schöttger. I'm actually the head of the department. I'm an anesthesia in the University Hospital of Lausanne in Switzerland. I'm a strong advocate of VL. Introduced it to my department in 2007 when it was barely there. Learned a few things, learned what not to do, and trying to teach the message of how to improve first pass success rate very quickly.
Yeah,
we did quite some research in the field of VL, also in relation to COVID. And we just published a paper recently about the impact of COVID on using the VL and what happened after COVID. So interesting messages to keep pushing the message forward that it's a fantastic device, and it brings the team together.
Yeah.
And what we need to improve airway management is not only technical skills, but it's non-technical skills, bringing team together, understanding the problem, and finding better solutions.
Yeah. So what has come after COVID?
Well, although during COVID, everyone was using it because it was so fantastic, and you was putting some distance between the source of the injury or the problem and your own. Afterwards, some people have gone back to the old times. It's kind of difficult to understand really why, and there are some issues there, and also depends on the local settings. But we need to keep pushing the message, hey, this is better, easier, more fun, and brings the team together. So let's improve.
And I think that we talked a lot about that in the podcast that we recorded. I recently was listening to some of the older content, and I love that about that aspect. We talked about how anesthesiologists, anesthesia providers, and clinicians, there are other benefits to doing some of these things. So again, I think we'll dive into that in just a little bit. So guys, just to revisit, whenever we were in Glasgow, I think Monty was doing the interview, and I think he was saying, is this conversation closed? Isn't VL everywhere? And I think for a lot of us see it quite a bit, but as we are hearing now, that this conversation is definitely not over, and it sounds like maybe we are even going in the gangbusters in totally new directions and hearing some new things. So what do you guys think, Ross?
Well, I think you've hit the nail on the head. Particularly in the developed world, VL is everywhere. It's become ubiquitous, but its use hasn't become ubiquitous. And we seem to have some inertia of people changing their practice and picking up VL and using it as their routine go-to everyday advice. Yeah, as you say, the evidence is there. Certainly, we can say conclusively in adults undergoing tracheal intubation in the operating room and almost certainly in the ICU, VL is a superior technique, fewer complications, better success rates, etc. Getting our colleagues who are not enthusiasts such as ourselves to buy into this message when they're now going to retire a device that they're very familiar and comfortable with. They almost seem to be a bit reticent to let go of their direct laryngoscopes.
Yeah, I know I hear it a lot because I actually have adopted the technology I've been using it for a long time, and I primarily would only use it on a difficult airway. But now I pretty much use it routinely for everyone. I'm not in the OR as much in the current role that I'm in, and I feel like, you know what, first pass rate's the best, and this is what I'm going to go with. And so embracing that has been easier for me. But I have plenty of colleagues that say I'm never going to give up DL and give up my blade. So Ellen, what would you say to that?
I would say if we practice evidence-based medicine, there is enough evidence there now, particularly now, that you've improved first pass success, decreased hypoxia. And with all the work we're doing now on the guidelines on unrecognized esophageal intubation, I think, although it's rare, unrecognized esophageal intubation, but it is fatal. It does happen. It's happening in, say, UK 4 or 5 a year. We know of, might be more. So it does happen to good people, experienced people who, as you say, maybe have used DL all their lives. But if you want to reduce that, we know that you will get better success, first pass success with a VL. So I would be encouraging them to change, and particularly saying to them, look, the MAC blade is the same as your DL. Yeah. And it's just that, particularly, I hate to say it, as you get a bit older, the view is better. And you don't have to wear your glasses. And ergonomically it's better because it is. To bend down. I mean, these things are important, but also that it is a better view, and it has been proven to be, and it's not that much different. I would like to encourage them even to use the hyperangulated blade, but that's another step. And in fact, even where I work, which is a big teaching academic hospital attached to university, people have moved more towards VL, but I'm finding the bigger problem in my institution is to get onto the advantages perhaps of the hyperangulated blade, which we're seeing now, the advantages of that, but it is another learning step.
Yeah.
But I mean, first and foremost, I think getting everybody to use VL first line and with for success, but also to reduce unrecognized esophageal intubation.
Yeah. Patrick, so we talked about like why people may or may not be interested in using this technology, and sitting here thinking about that, is VL almost too easy for people?
The Swiss are always very pragmatic. It takes time for people to change. We are discussing about the device that has been invented in 1943, and it takes time for people to understand that the thing they've been using for 80 years could be replaced by something which is made better, quicker, easier, and brings the team together. And I'm fascinated how people, at least in my institution where I promote universal use of VL, they find strange excuses not to use it. One of the latest excuses, they said, yeah, but if you use VL, I will lose my skills of direct laryngoscopy.
I hear that all the time.
And then I put my hand on the screen and say, hey, look it. And say, oh, actually, I can do DL because once we see a screen, everyone gets focused on the screen and forgets that actually you can look next to the screen.
Yeah.
And when I always record my intubations, I also record the way the people use them. And it's fascinating to see the movement of the eyes. They swipe from up, down, so you can actually generate a movement, a dynamic understanding of the intubation process.
Wow. Has anybody published that or looked at that or
maybe I should thought about it because I was going to publish it, but now it's too late. Ross will steal my idea and Anna will publish it.
I have to catch up to publication count sometime. This really gets my blood up, Patrick. There's a whole concept of, if I use a VL, I'm going to use my DL skills. It is an argument which is trotted out time and time again, and there is absolutely no evidence for it whatsoever. We should be affording it the same level of importance as hearsay, because we've never found a study which has shown skill erosion of DL when people start using VL, especially if your practice, and I know that you are a big hyperangulated blade man, but if your practice and your training starts with Macintosh videolaryngoscopy, your skills acquisition, I feel quite strongly, is actually better and faster. I can train all 5 medical students in the operating theatre on one intubation if they can all see the screen. What you were saying about bringing the team together. And in fact, some of the papers that are coming out now are suggesting that people may well be learning faster and novices performing better if they are trained from the get-go on VL rather than DL.
Yeah.
You've got to shift our whole mindset around.
Yeah, that's interesting about novices, because there was a suggestion of that in the device trial, which was done in the United States, a multi-centered systematic study by Precker and co. And that study was showing that people who the novices had better success with VL than a DL. It kind of merged after time, but when they picked up, if you're a novice, and these were mainly emergency residents and intensive care residents, if they picked up a VL, they had better success if they were novices than DL. And another review was just come out from Canada, a systematic review supporting the fact that they looked at novices, residents and students, and they had a higher success with the VL. So I think we may be changing our teaching now to saying we learn with a VL, you then teach them DL by turning the screen round, covering the screen, and then the hyperangulate is in a more advanced technique.
I think you may actually be able to learn DL better if you start with VL.
It's actually the case. And what I expect about bringing a team together is to extend the team. It's not only an anesthesiologist, it's the ENT surgeon.
Yeah.
And what happens now, the chief of ENT, they send the ENT residents in my OR room. I do everyday ENT cases. And they say, hey, look at what the anesthetist is doing. Look at their screen. So we bring the whole team together and we understand. When I was taught DL, I did never understand how to put a tube in a hole, which I didn't see.
Yeah.
Now I understand, and I'm not. Why do I succeed and my residents don't succeed? It's not because I'm better, but I understand where the tube needs to go. What's the problem? I try to find a solution. So this understanding is actually possible through the understand the viewing and bringing the inputs from the team.
Yeah.
I was talking earlier today in a session about teaching intubation skills, specifically awake intubation skills. But one of the points which I really tried to bring across the room was this concept of kind versus unkind learning environments, whereby you try and create an environment where it's easy for people to learn. And that is a kind learning environment is where you see direct, immediate feedback on what you do. You play the wrong note on the piano, you hear the wrong note, you know you've played the wrong note, you can practice playing the right note. When you're training someone on DL, we all learned the same way. You'd be desperately trying to see down a dark hole with someone leaning over your shoulder saying, can you see the chords, can you see the chords, can you see the chords? And you would shove a tube in somewhere in the hope that it was in the right place. That's not a very kind learning environment. That's a hostile learning environment. Whereas the moment we've got in the operating theatre a novice who's doing an intubation, and we can see everything that's going on, the moment I can see they are starting to do some part of the psychomotor skill of intubation incorrect, I can literally put out my hand and say, hold on, rather move the device like this. Do you see how that improves the view? And they've learned that skill immediately, whereas it would take a long time to unlearn the wrong skill if we can't see what's going on.
I was taken right back to when I was training in my own training and sitting there trying to intubate somebody, and everyone's, what do you see? What do you see? And then you don't get it. Like, oh, I think they're a little bit anterior, whatever the excuse is. I VL completely eliminates all that. I mean, it makes it more kind, but you can say, no, or yes, they are a little bit anterior, but move the blade just like this. And then that's how you actually see. I love that aspect, Ellen.
And I think there's a concept I like. It's called precision intubation. It's that, we're not making a stab at it like we used to. I think it's a black hole down there. You're actually looking at your structures. You get a wider angle view. And there's a guy called George Kovacs who's published a thing called glottic impersonation. And he's great pictures.
They're not jokes.
But he has pictures of what looked like to us a larynx. It's a kind of blanched, it looks like a larynx. And then you say to him, that's a larynx, yes, I'd intubate that. And then he shows you the wider angle view you get with a VL. And you see actually that was a kind of blanched esophagus because you're putting it under pressure. But the wider VL, the other was a DL, with the wider VL view, you can see both. And you'll always see that when you see your nice view of the cords. Underneath it, you can often see the opening of the esophagus. And this glottic impersonation, he's an emergency physician, and he says it happens quite a lot more than we thought in the past. And again, it's to do with avoiding esophageal intubation. And if the angle of the view is less, you may mistake esophagus for the trachea.
Now, I think making the case for using this in place of or instead of a typical Mac blade, I think for all of us Mac users out there, the right blade, it's an easy transition. But for those who may be used to using Miller, or you were talking about the hyperangulated blade, talk to us a little bit about, if you truly are changing the type of blade that you're using with VL. Ellen, do you want to start?
Yeah, I think we have an extra adjunct to laryngoscopy with the hyperangulated blade. Obviously, it's got more of an angle, so it helps in difficult intubations because you get a better view. The problem with it is the angle at which you have to intubate is more difficult. Yeah. So you need to practice that essentially to get the blade kind of round the corner. So just having a tube or a bougie doesn't work, and you'd nearly always need a stiletted tube, or at least a malleable stiletto or a rigid stiletted tube to get it around the corner. Mm. So that skill is, I would argue, advanced. And because people definitely aren't used, the Mac users, the original Mac, are not used to kind of not being able to get their tube in if they can see the view with either a bougie or just a tube. Yeah. So that's a technique we have to teach.
Yeah.
Sure. So I'm a strong advocate of hyperangulate. It's a totally different technique. It is. To compare it to laparoscopy. Okay, you can be good with one, etc. The thing is, as we've always been trained with the Mac blades, there was a strong correlation between the degree or the ease of visibility and the relation to difficulty. Now with the hyperangulated blade, you turn around the problem and you have a beautiful vision.
Yeah.
So, at the beginning, everyone is baffled. Oh, I see beautiful. Now it's going to be easy. No. You see beautiful, but now you need to understand how the tube still needs to go through the anatomy. And this is a step that the brain must process. Mm-hmm. And if you come from the world of visualization equals difficulty, it's totally wrong. And this is a process we need to implement within the brain that the
Yeah, that's true. I mean, you're seeing things that you never would, otherwise. Ross, what do you tell the Miller user?
I was going to jump on some comments about the hyperangulated, but then I'll get to your Miller.
Yeah.
So I think we made a critical area in our development of videolaryngoscopes, in that many of the early the progenitors of the whole videolaryngoscope movement, we're talking here about the CMAC-D blade and the GlideScope, both hyperangulated blades, were designed very much with the anatomically difficult airway in mind. And they were designed to be used in a specific fashion with different geometry. Yeah. We then put them in the hands of lots and lots of practitioners and said, here, this is better for a difficult airway. Whereas the people who developed those blades, studied those blades, came up with that geometry, had invented an entirely new motion and way of intubating. The tip of a Macintosh blade is nearly perpendicular to the handle. On a hyperangulated blade, it's nearly parallel. The way that you lift with a Macintosh blade is in the direction of the handle. With a hyperangulated blade, it's up as if you're lifting luggage. With a Macintosh blade, particularly doing DL, you're trying to maximize your view, as Patrick says, because then you know that you've got the right geometry to intubate. Whereas with a hyperangulated blade, it often behaves much better if you accept a grade 2 view because you're making more space in the airway, and the geometry with that is better than a more acute angulation to get a grade 1 view. So we have to train people with a mindset of actually the hyperangulated blades are specialized devices for the difficult airway, and the technique to use them is different. The moment you explain those 2 or 3 factors, then anybody can pick it up and can use it. They just need to understand it. We've actually failed our fellow clinicians by not providing that education.
Yeah, no, I think that's so true.
And what we've done now, because as I say, it is a different technique, and our fellows learn it, and we have a kind of a stepwise way of teaching it, because they say, oh, you get a good view, but you can't get the tube in. And that's been the mantra since VLs have come out. That's what your Luddites say, your DL users say, oh, I can get a good view, but I can't get the tube in, because they were remembering the first VL.
Yeah.
Whereas now we have a stepwise approach to teach, and we make it a kind of an advanced technique. But I think if you just pick it up and you kind of don't think about it, and you don't have a few steps to go through, you will fail, and you won't like the D blade. Yeah. The D blade or the X blade for McGrath or the GlideScope have a hyperangulated blade as well.
Okay, I'm going to keep asking this question until someone answers it. What about our Miller users?
I'll jump on the Miller. So traditionally we loved using Miller blades in kids for direct laryngoscopy because of the relatively large tongue in a trap. And that means we can use an ever so slightly paraglossal approach, and we get a nice visualization we can see. Now, videolaryngoscopes are very good at seeing around things. So actually using very small Macintosh blades in small kids actually works very well. So if you have got a VL which has got small Mac blades, they generally are fine. I particularly love the Miller videolaryngoscopes for specifically doing paraglossal intubations in patients who are quite tricky, whether that's kids or adults. And if you use some of the longer Miller videolaryngoscope blades that are available, particularly for those specialized paraglossal intubations, they're an absolute, and they're fantastic to use. You do start needing to shift your mindset, because it's almost like using a rigid bronchoscope or a rigid stylet in the technique that you're using. It's no longer a midline or a shift the tongues to put the blade in the midline approach like we used to with our normal laryngoscopes and most of our VLs. We're starting to talk paraglossal, and then eventually you can start thinking about retromolar with your stylets. But again, these are layers of advanced techniques above and beyond the everyday use. But I think for the airway enthusiast, these are the kind of things that we should be skilling ourselves in.
Wow, I did not even realize that they had Miller videolaryngoscopy blades.
They have for children. I'm not true for adults. We have them for children.
I have actually got a Miller 6.
Whoa, that's a sword.
It's about this long.
Excalibur.
But that's for a very specific purpose. That's actually used for intubating sheep. Very sick.
I was going to say an elephant. I wasn't very...
Sheep have got a very, very long larynx and very poorly formed vocal cords, so they're actually quite hard to intubate. It's also why they don't sing very nicely.
But just to reiterate what you're saying, our pediatric anaesthetist, I'm not in a pediatric centre, they all use the pediatric Miller blade, and then they wouldn't be without it. We have Bonfils, which is a kind of a rigid scope as well, which we like, but they're not that many Miller users ever in Europe. I think it was very much an American in adults anyway. I've never seen a colleague routinely use a Miller in adults in UK or Ireland where I've been. Yes, it's only when I went to Johns Hopkins to the US that I saw Miller's being used.
Yeah, I think it's a question of habit, right? I'm my best friend when I manage airway is the epiglottis.
Oh, really?
Yeah.
But most people would not say that.
No, because below the epiglottis you have the vocal cords.
Oh,
So I paid lots of attention not to touch it.
yeah.
And if you use the Miller, actually, you're challenging your friend, right? And depending on the situation, sometimes you might get some edema, etc. So I try to stay away from the epiglottis, always know where it is and have it in focus, and then I know where to go.
Yes.
But again, it's a question of habit, of culture, etc. I'm not a big fan of Miller, but again, I don't do pediatrics every day, so that's also the situation.
Yeah, that's great. Well, guys, we do have to wrap it up here today. I could continue to talk about this. This is great. I love hearing some of this newer stuff. Where are we going in the world of VL? Because it sounds like we're still, like I said, at the beginning, there still seems like there's a lot to learn in different spaces, techniques, different tools that are going to be coming forward. Patrick, didn't you say you just came off the stage earlier and we're talking about something?
Yeah, I think we need to diversify the way we bring the message across. And we just presented this a project about using virtual reality to teach. So virtual reality could be a great tool to improve the fun and improve the messages, and also train the technical and the non-technical skills, right? Because you need to have the input from the team. How do they react? What do they understand? That we're bringing the team together to improve the airway management in global. Yeah. So VR is one of the designs and one of the tools we could use.
Yeah, fantastic. Ross, from your perspective, what do you think? Where are we going?
I think we need to flip our narrative from what it's always been. VL is a tool for difficult airway. We need to flip it to VL is the everyday tool and should be used as our primary teaching tool for documentation, for making the theatre environment and the emergency department environment a team approach. We have specific VL blades and advanced VL devices for difficult airways. And if we want to preserve people's confidence in doing direct laryngoscopy, let's train them in Macintosh VL and then let them challenge themselves by using a Macintosh VL as a direct laryngoscope. So they've still got the bailout, but they have confidence that if they're ever in the situation of not having a VL, that they can use a DL.
Yeah. I always say, too, maybe this transition is, like you said, flip it. It's not just the narrative, but the actual technology. So in our hands, every day we have VL, and in our drawer, you can have an old, hopefully not expired, DL blade and handle.
I agree with what both have said, absolutely. But I think when I do an intubation, it's not about me, it's about everybody in the room. It's about, I always have a trainee, I have a fellow, I have an anaesthetic assistant, and they can all see what we're doing and we can discuss it. And now we're teaching our anaesthetic assistants to verbalize CO2 when they see it, but equally they can verbalize. I always say I can see the tube going through the vocal cords, and they're starting to say that now and look at it because the screen is there and they can all see it. So it's making intubation a team effort rather than me just doing it. What am I doing down that door?
Yeah, and everybody kind of wondering and what's happening and what's going on. Are they going to get it or are they not? Yeah.
Can I just ask a question? If we would be living in the world where the VL would be the device, and all of a sudden the DL would pop up,
I know.
Would we use it? Probably not. So I mean, we come from a different background. It has been there forever, and now we're trying to switch. If the situation would be the other way around, it would never go into the clinical practice. At least not as a first pass solution.
Yeah, absolutely. I think that's a wonderful point to end on. Thank you all so much for taking the time during this meeting. I know you all are extremely busy. I see your names all over the program, and it's wonderful. I want to continue this, so maybe next time we're together, we can talk about what's up next, and if we're getting to those trainees, and if we're making the change that we want to do.
We'll definitely see you at WAM in 2015.
Yeah, fun. So this is about that.
In Italy.
Yeah, I'm there. All right, guys. Well, thank you so much for listening to Top Med Talk. You can always find all of our conversations at topmedtalk.com. Last year's conversation at Glasgow. We've had other wonderful content on videolaryngoscopy. Please do check that out. We're on social media, LinkedIn, Facebook, Twitter. We are there. And YouTube. Now, I know some of you all are going and watching the videos or even listening on YouTube. We really appreciate that. Give us a thumbs up, subscribe to the channel. That always helps us out. And again, just thanks for listening and supporting Top Med Talk over the years. Cheers, everybody.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.